All right, everyone. Thank you so much for being here. I'm just going to get my screen shared and get our PowerPoint up. Can everybody see that okay? All right, thank you so much. So I very much appreciate each of you coming out during your very busy day to do a little bit of inpatient education. So as you know, my name is Corey. I work an inpatient and outpatient here at Magee with all of you, but I'm also in my master's program at Duquesne. And so one of our projects for this semester was to identify a learning gap for a targeted group of an audience and really provide an educational initiative for them. And so today what we're going to be discussing is prenatal education, particularly for patients that are on medication for opioid use disorder and really helping to prepare them for delivery. So outlined here are our objectives. So really this is going to act as a roadmap for the next half hour of what we're going to be discussing. So first, I just want to lay the groundwork and provide a little bit of examples from the literature as to why prenatal education is so important, as well as talk about the gap that I noticed from practice and also that exists in the literature. Then we're going to really go into the clinical care for our families and focusing on what education they need to be prepared for at delivery. So we're going to talk about the difference between neonatal abstinence syndrome and neonatal opioid withdrawal syndrome. We're going to talk about how parents can best support their infants during this period and what non-pharmacological soothing interventions we can educate them on to be prepared for at delivery. We're also going to talk about the social services that are involved during the postpartum period for any parent that comes in delivering on medication for opioid use disorder. And then we're going to just do a summary and a little case example at the end with some questions through the resource of Poll Everywhere. Okay, so just to lay a little bit of background for everybody as to why this is so important. So prenatal education, there has been a big push in the last decade or so to really be educating our patients. When we went to the literature and looked in literature, we found that patients that had prenatal education had more positive outcomes at delivery. They found that they had a positive perception of childbirth, and it actually helped to prevent psychological birth trauma, which I thought was very interesting. In particular for our patient population, so those with histories of substance use that are on methadone or buprenorphine, which are medications for opioid use disorder, they found that when patients were educated in the prenatal period, they had an increased rate of breastfeeding, which is very important. And we're going to talk about that as a non-pharmacological intervention for infants with NAOS or NAS. And it also decreased the length of stay for infants with neonatal abstinence syndrome and increased safe infant sleep, which is important for all families as the infant mortality rate is unfortunately on the rise. So in looking at the gap, how did I identify this? So as many of you know, I've transitioned to working more on the inpatient settings and consulting with families as they come in for delivery. When these families come in to deliver, we obviously have in-depth conversations. And what I've been hearing a lot of the time is that they were not educated in the prenatal period by either their OBs or their medication clinic about really what to expect when they come in. So they didn't know that their infant was going to have to remain for a period of observation. They did not know that there was really this great of an impact on their infant. They didn't know they would have the opportunity to stay in our nesting program or the PPU. And they did not know that there was going to be any type of social service involvement at delivery. So I really was curious, is this just a Magee problem or is this a national problem? So when I took to the literature, I found there was very, very limited information specifically surrounding prenatal education for any patients that have a substance use disorder. And so I really figured that this is not just something that our office needs, but truly is something that other obstetric offices would benefit from and other medication clinics as well. Whenever I talk about neonatal opioid withdrawal, I always want to first just lay the foundation as to why this medication is so important during pregnancy. Many times we are asked by our patients or their families or other healthcare providers, why would we recommend prescribing a medication that would potentially have an impact on an infant? And so truly, it's the core foundation of you're not able to have a healthy infant if you don't first have a healthy mom. And so what we talk about here is understanding that when women are on this medication, they're engaged in a clinic and a resource. As you know, our team here is interdisciplinary. We have nurses, we have social workers, certified recovery specialists, advanced practice providers, doctors, who really can wrap their arms around women to provide them resources necessary for the success in their recovery. And that is the same with anyone going to a clinic on this medication. So they have increased access to resources, increased access to prenatal care, which increases the outcome of the positive outcomes of the pregnancy. They also can be engaged and assessed for any barriers to treatment. So do they have housing? Do they have proper childcare or transportation? Physiologically, we know that medication for opioid use disorder, methadone, buprenorphine, we know that these things work. There is research about it. Patients that are on these medications have an increase of about 30 to 40% increased likelihood of retention in treatment, retention of abstinence from illicit substances compared to their patients that are not on these medications and kind of just go with the abstinence method. So we would never want to ask a mom to choose between her recovery stability and becoming a mother. And then physiologically, we also know that it positively protects the fetus. So it protects the fetus from intrauterine withdrawal, decreases the likelihood of preterm labor or placental abruption, and it provides a stable environment for the infant in utero. All right, any questions on the background? I'm going to move in now to the clinical care of the infant. So this is really the meat and potatoes of what we're going to be wanting to provide education-wise to our patients. So any infant that is exposed to opioids in utero, at Magee, we have an observation period, and it's a minimum of 5 days. The reason that it is this amount of time and period of time is because the different types of opioids have different half-lives. And so some infants will have peak serum or peak withdrawal symptoms at different time periods, depending on the medication exposure. So methadone is the longest acting opiate. And we see peak symptoms typically on day 4 to 5. And so that's why we want to make sure they have the peak resolves, and then we know it's safe for them to go home. Okay. So to discuss the difference between NAS, neonatal abstinence syndrome, and neonatal opioid withdrawal, NAS is really an umbrella term. So there are many different substances in which infants are exposed to in utero that they may experience withdrawal symptoms from at birth. These include tobacco, benzodiazepines, stimulants, alcohol, even some mental health medications. But patients that are on this medication for opioid use disorder, on MOUD, their babies are specifically going to be observed for neonatal opioid withdrawal syndrome. And this comes from patients on any type of opiate, whether that be illicit opiates, prescription opiates, or medication. So how do we observe their infant? What are we looking for? How do we assess them properly? This is really what parents want to know. They want to know, what am I going to be able to do to minimize the effect on my infant? So the way that we assess them are 2 main scoring systems. Number 1 is Finnegan scoring. It's a more historical model. It really looks at objective signs that infants may experience in 3 categories. So central nervous system disturbances, autonomic nervous system disturbances, and gastrointestinal disturbances. And when we move into looking at the non-pharmacological soothing interventions that that we're able to use, I'm going to break these categories down a little bit more so you can see the symptoms and what they look like. We are moving from this model and using it in combination with this next model known as Eat, Sleep, and Console. This is a model that came out of Boston Medical Center around 2014, 2015, and it really has been a game changer for our patients. So instead of only objectively looking at the infant, this assessment method really partners with the families. So it allows us to empower the parents to really know their infant, look at them holistically and see, are they able to eat? Meaning that they are not losing a substantial amount of weight, they're thriving in that area, they're able to keep their food down, are they able to sleep for greater than an hour, and are they able to console within a relative period of time, meaning like 10 to 15 minutes of getting upset. If all 3 of those things are happening, we know the infant does not need medication intervention. The reason why we try to keep away from medication intervention is because it has a big impact not only on the infant, but also on the length of stay, the cost to the hospital. There's a numerous amounts of reasons as to why, if we can't have infants that stay only 5 to 7 days, that's much better than getting started on morphine and having the potential treatment for 2 to 3 weeks. So when we discuss our non-pharmacological interventions, this is really where we hone in on educating our families. So the main categories we look at are feeding, which is where we try to utilize those soothing interventions to help with the gastrointestinal disturbances that infants may experience. So babies may have a little bit more of an upset stomach. They may have increased spitting up. And so the way we can minimize these symptoms without using medication is by providing breast milk. So it is absolutely 100% safe to breastfeed on this medication. We know that there's a small trace of the medication that actually passes through the breast milk. When this happens, it is not enough to cause a continued dependency for the infant, meaning that when they stop breastfeeding, they're not going to have more symptoms of neonatal opioid withdrawal. But the breast milk is made specifically for that baby. It is the easiest thing for baby to digest, and so that's why we encourage it so much. We also want to be teaching our patients, what does my baby look like when they're hungry? We want to help them understand the feeding cues so that they're not to the point where they're inconsolably crying because they're so hungry. We intervene before that. And then we want to provide them with small, frequent feedings so it's a little bit easier for their bellies to digest. In regard to sleeping and consoling, this is really to help soothe those central nervous system instabilities. They may see things like tremor or tight tone, as well as autonomic instabilities of temperature irregulation, modeling of the skin, chin excoriation. So when we can help console the child, it means helping the parents understand what proper swaddling is, how to soothe them, to create basically the womb outside of the womb. So we want it to be a low light simulation, a little bit of like background white noise, and we want them to utilize skin to skin because that helps immensely with temperature regulation. So how do we support this at Magee? Any parent that comes in to deliver on this medication is able to stay in our parent partnership unit or our nesting program. It's an in-hospital program that really helps to foster empowerment in families to understand that they have the ability to be the best patients. They have educational and self-care sessions for the families. It provides them a place to stay during the observation period because mom is no longer a patient. So when mom comes in and delivers vaginally, she'll be discharged on day of life 2. If she delivers via C-section, she'll be discharged on day of life 4. And when this happens, they were in the past asked to leave and they were separated. So you can't have all of these non-pharmacological interventions when mom isn't able to stay at the hospital. And so that is why this program has come into place. And as you can see on this slide with our data, it has had a tremendous effect on the need for medication intervention. So in this first table, you're going to see the last 4 years of results from the parent partnership unit, and it tells you the number of patients that stayed, and then it goes into telling the number of patients that needed pharmacological intervention. As you can see, in 2022, there was a little bit of an increase. We are attributing this to a variety of different things, one of which being the fentanyl crisis and the way that fentanyl is interacting differently with infants and their withdrawal process, and also because we've expanded our eligibility criteria of the PPU. So we want more parents to be able to stay with our infants. And then the second table is a comparison from 2020 because the state's data is a little bit behind. This is the most recent data they have about their pharmacological intervention when utilizing Eat, Sleep, Console. And it compares our rate that year, which was about 1% needing intervention, and compared to the states of about 20%. So you could see we're well under the average, which is incredible. All right. Any questions about the clinical care piece?
Have you seen a difference between infants who are exposed to methadone versus infants exposed to?
That's a great question. So the question was, have we seen a difference in symptom outcome for patients that are on methadone versus patients that are on buprenorphine? And so there really was not a lot of good data on this, but recently, I believe it was in 2022, there was a study that was published, and it was a pretty robust study that did look at the physiological differences, and there was a slight decrease in the need for medication for infants exposed to buprenorphine versus methadone, but there's really not a great reason as to why. That's something they're still investigating. I feel like in our nesting program here, I don't know if I've noticed a big difference in that. So I don't think that's something that we necessarily track, but it would be a really good idea to see if we could have our own data for that. Does that answer your question?
Yes.
Cool. Yeah, thank you. Yes.
Why doesn't mom just
Yes, that's a great question. So the question was, why does mom not taper off during pregnancy? Why do we risk exposure to the infant? Am I hearing that correctly? Yes. Okay, cool. So really, there's a couple of reasons for this. So if someone comes in active use and they're pregnant, we don't have a very safe mechanism and way to monitor baby in utero for withdrawal. If we keep mom nice and stable throughout the pregnancy, we then can monitor baby very safely at birth. And if there are significant symptoms, we have ways to intervene and treat the infant. And so the risk for the infant is way less if we provide them stability throughout their pregnancy period and then after delivery, observe them for treatment. So that's why the recommendation is to stay on. Those are great questions. Any others? We're good to move on to this next section. Yeah, okay. So this last section is really preparation for discharge. So our families are going to want to know, okay, they have to stay for this observation period, but when is it going to be safe for me to take my infant home? So on this slide, you'll see the discharge recommendations from the American Academy of Pediatrics. This is from 2020. They had a statement, and they really go through what we look for. So as we talked about earlier, infants will have a peak in symptoms. Really what we're looking for in the hospital is that that peak occurred, it's resolved, and that they've had no significant clinical signs of withdrawal within 24 to 48 hours. We also want to ensure the parents are set up for discharge. So do they have a pediatrician that they have an appointment with that they're going to be able to do? Are they set up with early intervention resources, which we're going to talk about some of the social services that we have to offer? And are they really feeling comfortable with the newborn safe newborn care and emphasizing safe sleep? This is a wonderful quote that an awesome social worker that I worked with provided to me, and I think it really encompasses what we try to do for our patients. So it says, when a flower doesn't bloom, you fix the environment in which it grows, not the flower itself. And so honestly, that is what I believe our clinic does an excellent job at, it is breaking down barriers to help families have a successful environment so they can do their best. As you can see on this slide, it just goes through a variety of different barriers to best parenting. One that is important to address is stigma. And so often in society, there is like this thought that people that have a history of substance use disorder or that are on this medication are not safe to be parents. But when we can provide them with a myriad of social support and resources, truly they do amazing. So we want to be asking about their transportation, about their childcare, about their food insecurity, making sure that they feel understood and they're connected to all those resources, especially when they're coming in to deliver. And when we can identify these in the prenatal period, it just sets them up better because you're not trying to do everything and scramble at delivery. And then lastly, just to talk about social support upon delivery, and really our social work team is excellent at this, and it should be more so their role to discuss this with the patient than us as clinical providers because they have the expertise. But something that does happen is when there is a substance exposed infant in the state of Pennsylvania, there is a notification at birth to Child Protective Services. This is very different than an active child line or a report of abuse. It's really just notifying the state that an infant was born exposed to medication, and then it provides like the information about the mom, if she's stable in her recovery, what medication she's on, and then they kind of either file it as information only or based on their past history, choose whether they're going to investigate further. But it's very important because this can feel really stigmatizing for our patients if they deliver and they didn't know this was going to happen. So really discussing it in the prenatal period is crucial. There's also something known as a plan of safe care, which I've had the privilege of being able to do while I've been inpatient in the last couple of weeks. It's really just connecting them with and assessing for needs of resources and referring them then to this county agency that refers them out to the appropriate things. So they might need breastfeeding support or lactation support after going home. They may need physical items like diapers or wipes, getting them enrolled in WIC. All of those things are something they can help with. And then other interventions is something called early intervention, which any substance affected infant is eligible for. And then also our social work team will always assess for basic needs and the social determinants of health. All right, so the last key takeaways. Every family that comes in, whether it be through their obstetric provider, through their medication clinic, really should be having these main areas discussed. So we want to always be educating them why this medication is safe in pregnancy, and what their delivery will look like. So talking about nows, talking about the observation period, helping them know what to expect. We also want to be educating them about the social services available at delivery and what they can do to best support their infant during this time. And that they will be able to stay with their infant the whole time. That is very important. We never want families to feel alienated from their care. So, all right. That is like the biggest presentation point. We're going to move into a case, but I first wanted to see if anyone else had thought of any other questions.
How do you prevent a baby from becoming addicted?
Ooh, that's a good question, Tracy. Okay, so the question was, how do you prevent, or are babies born exposed to this medication addicted? And that's a really good question. So when we talk about substance use disorder, it's on a continuum. On one end, there's dependency. And then the other end, the most severe form of a substance use disorder is addiction. And so when addiction occurs, there are physiological changes in very primitive parts of our brains, like our reward system, our prefrontal cortex, our amygdala, limbic system, all of that gets changed. And there's continued use despite all of the negative social and health consequences that are happening. When an infant is exposed to this medication, they do not have that cognitive development to even have any of those systems be changing or affected by the opiate. So they cannot be born addicted. They are born dependent. Their bodies are physiologically dependent, but we have a very safe way to wean them. And they're born affected or exposed, but not addicted. That's a really good question.
So if they're not born addicted, then why do they need all the social services?
So if they're not born addicted, the question was, so if they're not born addicted, why do they need all of the social services? Truly, there is not a lot of evidence based on the long-term effect of exposure in childhood development. And we know that environment, genetics, all of this plays into childhood development. And so we want to provide extra support for the families, because the infant themselves may not need the support, but the families do, in order to be connected to a network of support systems. So that's why we offer it to the families. And they are optional, like the plans of safe care, early intervention. If the families are set up, they don't need to accept those services, but we want to be blanket offering them to everyone so no one gets missed. Excellent, guys. Good questions. All right. Any others? We're going to move into the case. Cool. Thank you. All right, so this is our practice patient. Her name is Jade Doe. She is 28 years old. She has a history of opioid use disorder. She is currently taking 16 milligrams of buprenorphine, naloxone, or Suboxone daily. Her history of present illness. So Jane presents to the clinic today, about 10 weeks and 2 days gestation, and she explains that this is her first pregnancy. She's very excited about it, but also very fearful. So she has been very stable on this medication. She's been on it for about 4 years, with getting it through another prescriber, but was referred to us because she became pregnant, and her OB said this clinic specializes in pregnancy, you should go here. And she's really asking a lot of questions. She's wondering about remaining on Suboxone during her pregnancy, and if that really is the best thing for her and her infant. So we're going to go into a poll everywhere. So I'm going to stop sharing my screen really briefly. I'm going to share again. Go to this. All right, can everyone see the questions okay? Awesome, thank you. So you're going to want to text 37607, and then you're going to want to text Corey Davis 017 to that number. Activate this. Okay. All right, so what piece of education is not accurate and should not be shared with Jane at her initial visit with you all? I'm just gonna let you read them yourself, or I'll read them. Infants exposed to Suboxone are born addicted, and she should taper off of her medication. Discuss the risks and benefits of remaining on medication for opioid use disorder during pregnancy. Briefly introduce neonatal opioid withdrawal and the PPU, or tell her that infants are born exposed, independent, but not addicted. All right, good job. A, yes, that's correct. We would not want to recommend she taper off of the medication. Next. All right, we're fast forwarding. So Jane is now 34 weeks. So she's preparing for delivery of her infant. She is asking you why her infant's going to have to remain for observation. So what pieces of education do you want to provide for her? Are we going to want her to be monitored for NOWS or NAS? A or B? NOWS. Good job. Yes, that is absolutely correct. Good job. All right. Tracy, do you mind grabbing my charger? I'm just nervous my laptop is going to die. I just don't want it to die in the middle of this. Thank you so much. And I think there's an outlet back here. That's okay. All right. This one is, thank you. Jade will not be able to stay with her infant because infants with NOWS have to be transferred to the NICU. True or false? Thank you so much. I appreciate you doing that. False, that is correct. So she will be able to nest in with her infant. The infant does not have to be transferred to the NICU. She will remain in the parent partnership unit should she choose to do so. All right, in describing how her infant will be monitored, what scoring systems are you going to explain to Jade? Is she going to use the COWS score, Finnegan scoring, Eat, Sleep, Console? Awesome. Yes, so we use combination here. We use Finnegan scoring and Eat, Sleep, Console together just to see the overall picture of the health of the infant. Awesome job, everybody. All right, in asking about breastfeeding, she wants to know if it's going to be safe to breastfeed. Her provider tells her that it absolutely is safe and recommended. Is that true or false? True. Awesome. Excellent work. Almost done. 2 more. So when talking about non-pharmacological soothing interventions, what is a way that we would not recommend she care for her infant? So talking about large feedings, you see a lot of people hitting large feedings, that's correct. So we're gonna want to do small frequent feedings to ensure that baby has a lot of time to absorb that and we're not overfilling their bellies so that they have increased spit up. All right. What should social work we be reviewing prior to delivery to ensure she is not surprised? This is an all of the above or some question. Amazing, all of the above. Good job, guys. So plans of safe care, early intervention, notification to CPS. Great. And then last one, and just reviewing all of the ways that we're going to want to educate our patients prior to delivery. So these are the key points we summarized. Amazing. Great job, everybody. I appreciate all of you. You did an excellent job. I hope that this was somewhat beneficial to you in your practice. Thank you, Cam. I appreciate you. If you have any questions about any of this in the next coming weeks, please feel free to let me know. But I hope you have a wonderful rest of the day, and I'll be up here if you have any questions. Thank you. Thank you. Thank you. Thank you.